Hey guys, and welcome to another episode of the Living Better podcast. Today we have an interesting interview. It's going to be in three parts, and it's with Dr. Pete Kelly from the Ottawa Institute of Cognitive Behavioral Therapy. So today we're going to talk about mental health, and it's going to be very interesting. We cover a lot of subjects. We're going to give you tips and tricks on how to improve your mental health. So we're talking about different disorders. We're talking about cognitive behavioral therapy and how it can benefit people. And we cover a lot in those three parts. So it's going to be very interesting. So please go from 1 to 3 and listen to the whole interview if you can. We would really appreciate it. Also, subscribe to our channel if you can. It's very beneficial for us in a way that encourages us to do more interviews and to see that the crowd's growing and that our listeners are enjoying the material we put on. So before we get there, I'd like to talk about our sponsors because it's important. It's part of the podcast. So our official sponsor is the Sleep Monkey Premium Sleep Mask. I talked about it in the other podcast. It's this amazing sleep mask. It's really life-changing. It's the only mask that me and my wife found that blocks the light totally well and is comfortable. So it's very hard to find a sleep mask that does both. Either it will block the light but will be uncomfortable or vice versa. So the Sleep Monkey Premium Sleep Mask, it's an award-winning sleep mask. It's the only one that will give you what you need for your money. You're going to buy it once. It's going to be good forever. So check it out. The links will be in the description. Also, we have a newer sponsor. It's the Perfect Sleep Pad. The Perfect Sleep Pad is a cooling pad that's regulated by a machine, a system that circulates water throughout the pad that you put on top of your bed. And what it does, it is constantly exchange with your body the temperature to bring it to a comfortable neutral position. What this does is that it increases your sleep quality. So we're really in favor of quality sleep. So the Sleep Monkey Premium Sleep Mask combined with the Perfect Sleep Pad is really what you need if you want to change the way you sleep forever for the better and have a better quality of REM sleep and deep sleep. So check it out. If you use the code LivingBetter20 at checkout, you get this amazing 20% discount on anything that you order on the website, perfectsleeppad.com. Once again, the perfectsleeppad.com. Use LivingBetter20 at checkout and get 20%. Also, throughout this interview today, we're talking about meditation as well. Meditation is something that's really good for mental health. It's really good to make you learn to cope with different situations in your life and to control your own reactions in regards to stressors in your life. So if you want something that's really good and amazing, check out the Muse 2 or the Muse S. It's this headband that you put on, and it gives you instant feedback of how you're doing throughout your meditation. So you put AirPods or headphones in your ears and connect it to your phone, which is Bluetooth connected to this headband. It's going to tell you if you are in the right state of mind or in the right zone, which is the beneficial one, and it's called the calm zone. There's the neutral zone and the active zone. So it's going to show you with stats and graphs after your session how good and you did, and you can actually see improvement as you go. And the good thing is you hear this, let's say the ocean, or you can choose whatever you want. The louder the ocean is, the poorer is your meditation. And when it's really stops and you start hearing birds, then you know you're in the right zone and you are in actually this perfect spot when you're thinking about nothing. So check it out. That's the Muse. There's the Muse 1, Muse 2, and Muse S. So I'm going to put the links in the description. Feel free to buy it off Amazon or anywhere else that you find it. So without any further ado, let's meet up with Dr. Pete Kelly, clinical psychologist for the Ottawa Institute of Cognitive Behavioral Therapy. Sorry, it's a long name. Anyways, see you there. Ciao. There you go, and we're live. So thank you, Pete Kelly, for being with us. And today you're on the Living Better podcast. We're going to talk about mental health, mostly cognitive behavioral therapy, which is something that we've been very interested to learn more about and how it can help people. The goal of this podcast is always to bring more knowledge to people on how to improve their health, mental health, physical health, with tip, tricks, interviews and stuff. So we're super excited to have you on. So if you would go ahead and introduce yourself, tell us a bit more about you and what you do at the Cognitive Behavioral Therapy Clinic in Ottawa.
For sure, yeah. So again, like you said, my name is Pete Kelly. I'm a clinical psychologist registered in the province of Ontario. I've been at the Ottawa Institute of Cognitive Behavioral Therapy for about the last 10 years. Prior to that, I was at the Royal Ottawa Hospital.
Wow.
And so I do a lot of work with anxiety, depression, post-traumatic stress disorder. I do quite a bit of work with Ottawa Police Services, OPP, Veterans Affairs.
That's awesome.
I also do a lot of work. Yeah, it's really great work. We can elaborate on that if you wish.
Yes.
Really like doing that kind of work. Do quite a bit of work with personality challenges as well. I'm quite actively involved in supervision and training of both clinicians within our institute, but also of other healthcare providers in the community as well. I used to teach at Carleton quite a bit. I'm doing less so of that these days, but I'm a adjunct professor in the Department of Neuroscience there, and a professor in the School of Psychology as well. Clinical professor, so not faculty, but anyone who's involved in supervision gets that appointment. So it's that's my designation there.
Wow, that's pretty awesome.
That is amazing.
Good introduction.
For you.
So what brought you to working in the psychological field as a psychologist growing up?
So it's been sort of an interesting journey. So I started out actually in my master's doing a lot of animal research. I was doing psychoneuroimmunology, basically the interaction between the brain and the immune system. And what ended up happening is that I actually ended up getting really allergic to the animals that I was doing the research with. So I was doing a lot of brain surgeries, implanting cannulas, injecting chemicals into the brain, withdrawing chemicals to assess what was going on. And I actually I couldn't be in the building anymore because my allergies were so profound. So I switched over to human research, completed my PhD, and then I worked at the Royal as a scientist. And then working with the clinical psychologist there, I got interested in clinical psychology and decided to do a respecialization. So I went back, did a respecialization, and worked at the Royal for a little bit as a psychologist, and then transitioned over to private practice exclusively in 2010 or 11, something like that. And so I've been at the OI CBT ever since.
Wow. That's awesome.
That is amazing.
That's a good background.
Yeah.
So it's been I've really appreciated having both the strong research background and especially a very strong neuroscience background, and then marrying that with clinical psychology. It's been really helpful for me in terms of explaining to clients what's going on with mental illness, because I have been able to leverage that understanding of the brain in order for them to be able to understand what's going on with themselves.
Yeah, no, and exactly. That's something that people are becoming more aware now, mental health and the brain. It used to be all about physical exercise and being in shape and whatnot. And we find that nowadays, there's more sensibilization to mental health. So if we talk a bit about that, the clinic specializes in cognitive behavioral therapy, right? So if you could expand on what it is, what it does, and how it works.
Sure. So for cognitive behavioral therapy, we have a 5-part model that we use to understand just about any form of human difficulty. So typically we start off with thinking about the trigger or the environmental stressor that's going on that would cause the difficulty. From there, we think about the person experiencing a series of thoughts that might come along with that experience. We call those typically automatic negative thoughts, right? They come up automatically. You don't have to decide to think them. They typically are negative in their bias. That typically will then lead to certain physical sensations arising, like your heartbeat might start to go faster, your breathing might increase, your muscles might increase in tension. You also get emotions happening. We tend to think of emotions as being those one-worders like happy, sad, angry, jealous, upset, things like that.
Yeah.
And then from there, you get behaviors. It might be avoidance, typically fight, flight, or freeze. That's the easiest way to summarize that. And the beauty of the CBT model is that all of those 5 nodes interact together and they play off one another. And if you influence one of those nodes, you can get really good effects or bad effects, I guess, depending on what your perspective is going on at other parts of the model. So in CBT, what we do is we have a whole bunch of interventions that are designed to help restructure thoughts or change behavioral patterns or change one's relationship with emotions or to become less fearful of unpleasant physical sensations, right? So, and again, the beauty is that, say, even just by changing behavior, you're going to be able to change functioning at all those other different parts of the model. So that's essentially how cognitive behavioral therapy works. And again, you can use it to conceptualize just about any human difficulty. It's a very useful and portable model for understanding human problems.
Wow.
Okay, and that would be applied to anybody, about just anybody, or for instance, let's say somebody is bipolar, for instance, and comes to the clinic.
Right.
How would you help in that matter, let's say, with the CBD model?
Right. So what would happen is that you'd sit down with the client, you do an assessment, and your assessment would be a CBT informed assessment. So I'd be asking them, what are your environmental triggers? What are the thoughts that typically come up during times of struggle? What are the physical sensations you experience?
Yeah.
What are the emotions? What are the behaviors? Right. So I'd map that all out. And then what we do from there, we know there's very distinct patterns that will happen where I can give you. Do you want me to give you a couple of examples of some of the loops that we'll see?
Yeah.
Yes,
We have all the time.
Yes,
Don't worry.
please.
Just go ahead.
Okay, so I'll give you an example. We often tell clients that there's a very strong link between their mood and their behavior, their feelings and their behavior, right? And if you act like a depressed person, typically you'll end up feeling like a depressed person, right? Because all the behaviors that folks do when they're depressed typically end up generating outcomes which are consistent with that depressed mindset.
Wow.
Right. So if you wake up in the morning, you feel depressed, and then you just go back to bed. You wake up later feeling demoralized, and you just have a bowl of ice cream for lunch. Right. And then you end up going back. Then you feel hopeless. So then you just go back to bed. So see how that's it's like a chain reaction, right?
Yes.
Yeah.
Yes.
So that's one little loop. So the idea is if you act like the mood that you're in, you get more of that mood. A really helpful thing to do is that if you're feeling depressed, you're like, what would a not depressed person do with the next hour of their time? Hey, you know what? I'm going to go to the gym. I'm going to go for a walk. And by doing that, you generate new data that will pull your mood in the direction of the stuff that you're actually doing with your body, right?
Wow.
Okay.
So that's one loop. There's another loop where if people have fearful thoughts, let's say I've got a client with PTSD and they're fearful of going driving,
Okay.
Yeah.
right? They don't want to be in traffic. So what will happen is if they do that behavior, if they act out the thought and don't go driving, they're kind of proving that thought is true on some level, right? Because if that thought wasn't true, why would you bother not driving? Mm-hmm. So our behavior is very important in terms of validating our thoughts or not. So, and I could go on and on, but there's all these sort of feedback loops in there where we want to help the client understand, it's like, hey, you don't realize it, but by doing this behavior, by not challenging this thought, by trying to push away this emotion, you're actually creating you're creating more of what you don't want, not less, right? So it's like these self-defeating patterns of behavior that are embedded in the model. And it's really about educating clients about those loops and helping them to undo them with the techniques that we teach them. Excuse me.
And do you believe that by doing so, you would avoid people, let's say, taking meds in terms of depression? Like, is your talk that powerful that you can really change your whole condition or situation by breaking those patterns that you're talking about?
I think so. If you look at the evidence, it suggests that for moderate and especially severe cases, a combination of medication and CBT tends to generate the best outcomes. Okay. It's very common that someone with sort of more mild to moderate symptoms could get away typically without having to go the medication route. There's some folks for whom medication is extremely important. Okay. And it's a really critical tool. Often someone with psychosis or with bipolar disorder, that's almost always going to require some sort of a medication. Those disorders are very organic or biologically based, have a very strong genetic predisposition. Okay. Depression, it's less clear, right? Because there's a lot of different situations in life that can cause depression. So for instance, if someone's going through a divorce or they're recently unemployed, being depressed would just be a normal human reaction to that situation. It's not the case that we necessarily even want to medicate that quote unquote away. Mm-hmm. Okay. Right. So pain is inevitable in life, of course. What we don't want to do is get into a situation where someone's suffering unnecessarily and suffering to a point where they can't use the strategies that we'd like to teach them, right? Because you have some folks who the symptoms are so severe that they don't get a chance to actually even use the strategies. That would be a classic case where we want to get them to speak with their family doc about getting some medications on board.
Okay.
So you believe that medication in certain condition is almost mandatory, right? You won't get away from it.
However, something like bipolar, like you just discussed, is this something that you feel is curable, or this is something that you will have for the rest of your life?
So with all mental illness, we tend to think of them as more like chronic illnesses in the sense that we don't want to focus so much on a cure. We want to focus on effective day-to-day management through the consistent applications of tools and strategies. And also the client has to become the expert on their condition, right? They have to know all the ins and outs of it. They have to be aware of what their triggers are, what they need to do to stay healthy. So we really need clients to partner with us. It's a very active form of treatment. And again, people can have a remission of symptoms, right? Where if the stress goes down, if they're using all the right coping, they may find that their symptoms for the most part go away. But we know that they're always vulnerable to those symptoms coming back when stress becomes elevated. So for instance, in a time like we find ourselves now with the COVID-19 pandemic floating around, I suspect that in the coming days, weeks, and months, we're going to get extremely busy with folks whose symptoms start to re-present themselves after their stress being so high for so long, especially being isolated.
Yes,
Exactly.
absolutely. I agree.
Now, I had a question for you. In terms of people with mental illnesses, in our experience and in our surroundings, people that we know that have certain conditions, they tend to use substance abuse like drugs and alcohol. Would you be able to say why? And that tends to amplify their symptoms. So it's probably in your experience, you see a lot of people that's one of the challenge when they come to a clinic. They're having maybe substance abuse and mixed with meds and everything. They never get like a proper state of mind, right? Because they fluctuate and try to self-medicate, right?
Right. So typically what you see with substance abuse is that the person, there's often a very strong trauma history, and that can be trauma from childhood. It can be trauma later on in life. And essentially what that person is looking to do in that moment is to relieve internal pain through numbing of some kind, right? Or to escape.
Yeah.
And because it kind of works, I mean, there's no doubt about it, right? Like, I mean, if alcohol, cannabis, different substances, they work with respect to helping people self-medicate and achieve a temporary relief of their symptoms. I'll stress temporary, right?
Mm-hmm.
Yeah.
So that using substances is what we call negatively reinforced in that way. The difficulty is that you're not actually addressing the underlying problem. And often the withdrawal symptoms from using that substance create a worse condition than the person went into, which means they've got to use more substances and then they withdraw. So you can see the cycle that people start to get into. So for instance, in alcoholism, a real tipping point typically in the trajectory of someone with alcoholism is when they realize that they can drink in the morning to make their hangover go away.
Yeah.
Right. And so that's when things really start to accelerate. Alcohol itself is highly depressionogenic. It causes depression. Sometimes you don't even, if you're trying to do a proper assessment on someone, you don't even know what's really going on until they've sort of gone through detox and quote unquote dried themselves out. It could be that the alcohol alone was making them profoundly depressed.
Wow.
So, yeah.
Huh.
Wow.
And on that note, so we had a seminar at our work place, and they were talking about the brain development and cannabis, right? So for instance, not using cannabis before the age I think was 25 for women and earlier for men, or I'm not exactly sure. And would you say that maybe like substance abuse or even like drugs in your teenage years might trigger mental illnesses or make your brain not develop the way it should?
The right way it should, yes.
Yeah, so there's pretty good evidence that cannabis use before in early adulthood, just as you've mentioned, seems to set people up for potentially some cognitive difficulties. It also seems to be a risk factor in particular for psychosis, right? Schizophrenia, things of that nature. There's some question as to how much is there a chicken or egg sort of thing going on there, right? So adolescents who are vulnerable to psychosis often have what are called prodromal symptoms, right? Where they're a little bit odd, their thinking's a little bit different, they may be a little bit off in some way, quote unquote. And what we find is that, are those kids using cannabis to relieve their symptoms, or is the cannabis use causing those symptoms? It's not completely clear. But at the very least, I mean, certainly if I was speaking for my own children, I would be advising them to not use cannabis before, say the age of 22, 23, 24, something like that. I don't like the idea that it's legal for children who are 18. Absolutely. Myself. Also, to anyone who has a family history of psychosis, I would strongly advise them to not be using cannabis during their younger years when their brain is still very plastic and can be really influenced by those substances. Just as a general rule, the younger the person is, the more apt their brain is to be influenced by stressors, right? So we know trauma early in childhood really permanently changes the brain. It sensitizes a lot of the fight, flight, or freeze circuit, so that person is much more vulnerable to stressors in adulthood, right? So their body's physically changed as a function of that. One of the best predictors of PTSD in adulthood is experiencing childhood trauma, right? Just because it sets up tipping points within the brain, they encounter trauma later, and boom, everything falls over, and then you get the evolution of those symptoms.
And is there any way to make that disconnect with any techniques or anything? Or you're like, if you experience trauma, you're going to carry that trauma throughout your life till you die, basically?
Yeah, it's tough because that process of sensitization is actually, it makes a lot of sense, right? Because like you imagine, when you're born, it's like you're an alien showing up on the planet, right? You have no frame of reference. You have some instincts. That's about it. So imagine you show up in your family, your dad's beating you, your mom's neglecting you. Your brain is trying to figure out the world it's found itself in. It's like, geez, this is a pretty nasty place. I'm going to hedge my bet and make all of my reactions really in the service of keeping myself safe. I'm going to detect threat right away. I'm not going to trust people. Like that would make a lot of sense in that kind of family, right?
Yeah.
So what happens is that's actually a really useful process. So on some level, you would be going against the brain's natural inclinations to try and undo that. Now, obviously, if a child is in that sort of situation, they're going to benefit from counseling or support, or especially emotional support. So certainly wouldn't say, hey, don't bother doing that. We would absolutely say we want to get the kid out of that environment and we want to support them as much as possible. But I think what people need to understand is that early childhood trauma gets baked into people's physiology in a way that can't be readily undone. And they will live with that legacy for life. And again, that makes a lot of sense from the body's perspective. Right? Okay. So there's things we can do to nudge that trajectory in the right direction. But there's in the States, in the military, if you think about it, a lot of their infantry in particular comes from impoverished, low socioeconomic layers of society, right? And those folks have experienced tons of trauma growing up. And those are the very people who end up going into combat, where, of course, they're going to be experiencing trauma. They have very high rates of PTSD because the exact people who are the most vulnerable to getting PTSD are the ones who end up being exposed to potentially traumatic scenarios as part of their work in the military. So, yeah, I could go on and on, but society needs to be really aware of the profound impact of stress that is experienced early in life, and how they carry that through them for the rest of their lives, and it affects their physical and mental health profoundly.
Yeah.
Okay. So one of your job, I guess, is to make them learn certain mechanism on how to cope and deal with that, not to erase it, but to manage it better. Right?
Exactly. It's to work with the reactions rather than to try and push them away or pretend that they're not there. Huh. Right. And a big part of it is to help clients to understand that, all the strong reactions that you have, they made all the sense in the world for navigating the family that you grew up with. The problem is that you're not in your family anymore. You're out in the world with more or less relatively healthy people. The strategies that you used back then are not going to be a good fit for your environment now. It's time to adapt. It's time to change. And to, but you can appreciate if you were used to being beaten or neglected or taken advantage of, good luck trying to convince yourself to trust other people or to be vulnerable or to take chances, right? So it takes a long time to do that work, and the person has to I really admire folks who do that work. It takes a lot of courage to take those chances to try and, to unlearn some of the patterns that they had to learn early on in life.
Oh, yeah.
So you would say that they learn certain, I guess, defense mechanism or ways to cope when they're children, let's say, or teenagers, and then later on in life, those mechanisms don't apply anymore, right? They're not valid because the environment changed and they have to.
That's right.
And you grow up, right?
Yeah, I was reading, for someone that has, like, let's say, child abuse or something, right?
Mm-hmm.
By, let's say, their dad or something. Well, then throughout life, they're going to have boyfriends, husbands, whatever. Let's say for a little girl, for instance. And she won't trust that person because it will remind her of all, but it doesn't apply anymore. It's not the same, right? So exactly. I guess that's something you would do, try to break that link or
That's right. So we would identify all the rules and assumptions that they're operating by, right? So for instance, they might have a core belief like people are only out for themselves, or people, you can't trust other people. Yeah. And then what we would do from a cognitive behavioral perspective is we would set up a number of experiments that the person could do to actually test out whether those beliefs are true or not. And we would,
wow, that's amazing.
If you could give us one or two that you would do, like not the whole panel of tests, but just an example.
So for instance, let's say somebody, whenever they would go ask their parent or to express a need or an emotion to a parent, and the parent was always like, go to hell, go to your room, I don't want to hear your stupid complaining, right? Yeah. Let's say that was their experience. Yes. What they might do in adulthood is translate that to a boss, right? So say they have a need that's unmet. They might be fearful that the boss is going to have the exact same reaction as their parent. So what we would do is we would say, okay, let's do an experiment. Let's see if we can try and get our needs met in the context of a relationship with our boss, assuming they're not going to be a carbon copy of our parent. We would rehearse how to be assertive. We would develop social skills as necessary. We might role play it in my office in terms of I would pretend to be the manager. They would be themselves. They would practice articulating their needs, being assertive, and then they would go out and do it in real life to try and undo some of that learning that had taken place in childhood. And typically what people find is that if they're reasonable, assertive, and dealing with more or less healthy people, they're like, oh, wow, I actually can get my needs met. I can ask for the afternoon off for a doctor's appointment, and my boss just goes, hey, that's great, no problem. Thanks for letting me know. Just let HR know. So that would be an example of an experiment that we would do with people.
To make them realize that it's not as bad as they think. So as they do more tests and they realize, yeah, he's right.
That was the past, and
they start believing you. They start trusting you, right? So that helps with the therapy as well, right?
That's right. And if things don't go well, then we talk about it, right? And so one of the key ideas of therapy is that my job is not to convince people that the world is safe. My job is to convince them that they have the skills and courage to be able to navigate a world which is not inherently dangerous, but does indeed have danger in it. There are bad people out there, right?
Absolutely, of course.
We don't want people to be naive and to blindly start trusting people. It's more about finding the shades of gray and being like, yeah, we want to be able to we want to be able to detect accurately those people who are dangerous and we need to navigate away from. But we also need to be just as accurate with respect to those people who can actually meet our needs and learn to be able to be effective with them, trust them, be vulnerable, because there's a lot, you guys would know this from your own lives. There's so much wonderful things that can happen when you in a trusting, intimate, vulnerable relationship, right? It's a huge part of human connection, but you can't get there unless you're willing to be vulnerable.
I agree.
And that's what's really difficult for folks who have had trauma, is that they don't want to be vulnerable, and understandably so.
I agree. Absolutely. Well, I think you have a new patient. I'd love to come see you.
She had her fair share.
Yes, I've had my fair share. Yes, but it's okay. I just have a question. Looking back at my childhood, I feel like depression, anxiety, and all these mental illnesses have been around. However, like my grandma and my great grandma, it's something that was never talked about, and it was kind of frowned upon in a way. You never discussed your mental health. What do you think, or do you feel like mental health has always been there and always been the same, or has it been worse now today because of things like social media? What is your take on that?
I think, human nature hasn't changed all that dramatically since we evolved as human beings about 300,000 years ago, right? So a safe assumption is that more or less the incidence of mental health should be just about constant over time. Okay. I think there's a couple of things that are different now. Okay. Number one, there's a lot more awareness, right? And you're absolutely right. It's not sort of the family secret that it used to be, right? And it's funny, when I assess people, I'll say, mom, dad, grandpa, grandma. People say, well, grandma used to spend a lot of time in the bedroom, and there was some sense that she had a nervous breakdown, et cetera. But often families just don't talk about these things, right? So family denial is an extremely powerful force that has been, I think, suppressing a lot of this stuff. Mm-hmm. So I think there's more openness, there's less stigma, more people are open to talking about their experiences. It's also the case, though, and I'm going to try not to bore you to tears here, but the diagnostic and statistical manual that we use to diagnose mental illness has been sort of expanding in its diagnostic. So there's been what's called a diagnostic inflation. So there's more and more diagnoses that are coming online, and the criteria for those diagnoses seems to have loosened ever so slightly over time, such that more and more people are being diagnosed with mental illness, when I think it's debatable as to whether they actually have a mental illness or not. So I'll give you a quick example. So for instance, children, mental illness is now the leading cause of disability in children. Right? And how can that be? I mean, that just doesn't map onto our, and if it's not the leading cause, it's the second leading cause. I can't forget the exact stat. Yeah. It was also the case that, I think it's the case now that almost 50% of the population now ends up meeting lifetime diagnostic criteria for some sort of mental illness. And again, if 50% of the population is getting it, it starts to call into question whether that's actually, bona fide mental illness or not. So yes, and then there's the other layer too, is that I think we don't really have good cultural tools at the moment for dealing with some of the inevitabilities of life, right? So life to me under the baseline conditions is very difficult. There's lots of uncontrollability. There's lots of uncertainty. Lots of what we like to, I think, sometimes think of mental illness are simply normal human reactions to the very difficult but ultimately predictable scenarios that come up in life. So I think what we want to try to do, or where we should go, is try and reserve a diagnosis of mental illness to those times where it's very serious and sort of very unusual. And a lot of it debatably is perhaps a reaction to life that we all share and we all have in common, which we should be talking more about.
Absolutely. I agree.
Sorry, that was a very long answer, but
no, it's good.
No, it's amazing.
Talk as much as you want. We like
this.
it. You're awesome.
Thank you. That question is actually deceivingly nuanced, and it's a very deep question actually, because what it boils down to is, how do you define mental illness? How do you measure it? That's right. And that really, that's a whole can of worms.
And when you talk about that, I mean, the brain is still, in its early age of, we're keep finding more and more research and more things about the brain. So, someone that would be diagnosed, let's say bipolar, wouldn't be the same bipolar as, let's say, me, right? Because we don't have the same brain. We don't have the same neurons and connections and everything. So like you said, it's hard to put people in categories because it's the unknown, right? You don't see.
Well, exactly. And there's these funny little things, right? So if you look at depression, right, you've got to have either sadness or lack of interest or pleasure in things for most of the day, nearly every day for at least 2 weeks, right? You got to have one of those two. And then there's a whole other, there's like 7 or 8 other symptoms that you can have, of which you only need 5.
Yeah. Wow.
So because of that, you can have somebody's depression have one profile and somebody else's depression have an almost completely opposite profile, but yet we still call it depression. How would you even study something like that, right?
Yeah.
And then anyway, there's all these other interesting things too, where, perfectionism tends to go with depression almost all of the time. Suicide doesn't, yet suicide is one of the diagnostic criteria. Perfectionism isn't.
Yep.
Right. So there's these diagnostic categories, they're more reliable than they are valid, seems to be the case. They tend to be more inclusive than they are exclusive, right? So they tend to sweep in more people than perhaps that they should. And of course, that's had big implications for prescribing of medications, right? Because the more people who meet diagnostic criteria, the more people who are prescribed medication. There's probably a lot of folks, I believe the data suggests that there's a lot of people who are on medication who shouldn't, and there's a lot of people who should be who aren't.
Okay.
Right? So we've got a mismatch going on there.
Yeah, and I think that's something that's very challenging for people with mental illnesses, to find the proper medication, right?
Yeah.
So
yes.
So in your experience, what do medication do in terms of the brain?
So,
dopamine, all that stuff, right?
Right. So the 3 major there's about 4 major neurotransmitters that these medications tend to act upon. So you've got serotonin, you've got dopamine, you've got norepinephrine, and then you've got the opioids.
Okay.
And there's a whack load more, but those would be the major neurochemical systems that are being impressed upon by drugs when they're administered. The most common ones would be like the SSR, GABA as well. Excuse me. It's another neurochemical. So you've got your selective serotonin reuptake inhibitors. They impact upon serotonin. You have drugs like Wellbutrin, which impact more on dopamine. You have the benzodiazepines like Ativan, clonazepam, which act upon GABA receptors. And you have You have SNRIs like Effexor, which would act on both serotonin and norepinephrine. Then you have, like your Oxycontins, opioids, which act upon the opioid system. Ultimately, all of those systems are interconnected. If you're impacting one, you're impacting them all. And it's really complex. And I don't think there's anyone out there who can say with a straight face that they know exactly how all of those systems interplay with one another.
Yeah.
It's very complex. Couple key points, just to do a bit of myth busting here.
Yeah.
There's no evidence actually that there is a neurochemical disruption in depression, let's say. If anything, that's never been demonstrated, right? If anything, the way medications work is by torquing the system into an abnormal way of functioning, right? So I could go on a little bit, but I mean, there's same with dopamine and schizophrenia, right? Like, so the compounds, the antipsychotics act a lot upon dopamine, but it's not clear that it's simply a neurochemical imbalance with dopamine that causes psychosis. So we have these very simplistic models that haven't really borne themselves out. I think there's a long way to go with respect to understanding mental illness in the context of the brain. And again, how much of what are normal human processes and reactions are we labeling as mental illness simply because they're unpleasant and they don't tend to feel very good, if that makes sense.
Okay, so basically a medication would put you in an unnatural state, and if that state works better for you than the state you were currently, then you would say, right, that the meds work.
Yep, exactly. That seems to be, funny enough, that seems to be how it plays out. And that's, a lot, again, it drives me nuts when I hear that, it's due to neurochemical imbalance. It's like, nope, not as far as we know. If anything, the medications torque the system into imbalance of some kind that somehow yields a benefit of some kind.
Okay. And in terms of depression, I've saw some studies, and maybe you can clarify that people that are depressed, there's parts of their brains that shrink down, right? They become smaller, and medication would rebalance that to grow it back, right? Is that something that's true?
Yep. So there's some evidence that antidepressants, one of the ways that they work is that they promote the release of what's called growth factors within the brain, which are sort of like fertilizer within the brain, like I think BDNF, like brain-derived neurotrophic factor, right? So it prompts neurons to sprout and to grow. And yeah, in depression and PTSD and other forms of mental illness, you do see atrophy or shrinkage of some parts of the brain, and you also see a change in the functional connections between those areas of the brain. So for instance, you have the limbic system, which is sort of more that primitive lizard brain. You have your prefrontal cortex, which is more the thinking executive part of the brain. And the relative balance between those two can get out of whack. And it seems like medication works from the bottom up. So medication works on the more primitive areas of the brain that release a lot of neurochemicals up. Something like cognitive behavioral therapy seems to be top down, where it's almost like doing push-ups for the prefrontal cortex, which pushes back down on that limbic brain and helps to keep it in check. So two different mechanisms.
Okay. All right. And what's your take on meditation? So meditation has been something that you see more and more of. I started doing it myself, which I think is very beneficial. But from your standpoint on, psychologists and the brain and stuff, what's your take on it?
Yeah, so there's a lot of good data around meditation. It's something that I endeavor to do myself on a daily basis. I use Headspace, the app Headspace. There's plenty of other good ones out there. 10% Happier, Calm. I believe Sam Harris has one, Waking Up, as well. If that's not the name, it's pretty close. There's a lot of good data around it. I think the big value added of meditation is that it allows for gap detection. And what I mean by that is it allows you to get arm's length to the thoughts that are going on in your mind, and allows you to have a different reaction to those thoughts than the automatic one which you may have. So the best case scenario, someone might say, I've noticed that I've had a really angry thought come into my mind. I wonder where that's coming from. I'm pretty curious about, maybe what I want to do with that. What's the urge that goes with that? And by the time you think that through, you're like, yeah, you know what? I just want to put that in the category of a random thought. I don't want to do anything about that. And I'm going to remain interpersonally effective. So it's really helpful for people to allow people to introduce time and space into their behavioral repertoire to allow them to get out of that automatic reaction that gets us all the time. And if you look at the times probably where you've had the most problems interpersonally with people, it's where you acted out of emotion, right? Something came up and you sort of flash over. You're like, I'm going to send that email right away. I'm totally justified in sending this. And then you reread that email the next morning. It's like, oh no,
What did I?
Like, what did I do?
Right.
I agree.
So mindfulness can help you be like, okay, I'm having the urge to send a really aggressive email. I wonder where that's coming from. Oh yeah, it's because I'm actually really mad more about what's going on at home. I want to take it out of this person. This would be a bad idea. Okay, I'm going to sit on that.
Okay.
Yeah.
And one study that I've read is that it shrinks the amygdala, which is the fight or flight center in the middle of the brain. So by shrinking it and lessening the connection in between the rest of the brain, then your reaction to stress is lessened. Is that something that you think is valid in terms of a statement?
I don't know that particular finding, but and that's not to just confirm it. I think there's pretty good evidence that people who are regular meditators, they show a thickening of the cortex and the functional connectivity in the cortex, which is sort of more that thinking part of the brain as opposed to that more emotional part.
Yeah.
And it's very likely that through meditation, again, it's sort of like push-ups for that thinking part of the brain, is able to better suppress some of those primitive impulses that bubble up from the lizard brain.
Yeah, and another study I've read, because I read a lot. I love all this.
Yeah, it sounds like you're really into the literature. Yeah.
Yeah. And one of them was that it prevents cognitive decline. So meditation prevents your brain from shrinking. As you age, it shrinks, right? So you matter. So they did studies. It was a Buddhist monk or something, and the brain that he had at 70 years old was the size of someone at 40 years old. So
right.
Wow, you like, because he was a Delhi meditator for like an hour a day or something. And
right.
They thought that was very interesting, that his brain was a lot bigger than it should be for a man his age, So that's one step.
Yep. No, I think it's very interesting. And I mean, it's something that I suggest to all of my clients, particularly combined with breath work, working on your breathing, doing that deep diaphragmatic breathing. The vagus nerve, which goes up into the brain, is connected directly to the diaphragm. When you do that nice diaphragmatic breathing, you're sending a very calming signal back up through the vagus nerve to the brain, letting the brain know that everything's okay, as opposed to doing that sort of more panicked kind of chest breathing, panting, which sends an emergency signal back up to the brain. So that mindfulness meditation with a focus on the breath, with the combination of the diaphragmatic breathing, I think is a real, 1-2 punch, which was really quite effective for people.
Great.
Yes,
all right.
Of course. Is there anything else that you recommend to your patients as well to do, or is it mostly just breathing work and meditation?
I think all of my clients should be exercising.
Very good.
Right. So, and I'm a big fan of powerlifting. It looks like you might be as well.
Yes.
Looks like you've done a deadlift a time.
Yeah.
Yeah. Thanks.
So I'm a big fan of powerlifting, heavy weights. Cardio. But you know what? Listen, guys, at the end of the day, the best exercise to do is the one that the person will actually do.
Okay.
Right? So powerlifting is not going to be a fit for every single person. Whatever is a good fit for their physical state, their time, their motivation. But at the end of the day, everybody should be exercising. That therapy, medication, there's nothing better than exercise that we have to offer our clients in some ways. So I think everybody should be doing that.
Okay, great.
Good stuff. So we're going to have to stop for this part one of this interview. Yep. So we're going to move into part 2. So to continue on our conversation. So thank you so much, guys. See us in part 2 as we're going to continue this interview.